So I'm Dr. Jospitre. I'm a psychiatrist. I've always been interested in how to help people get better. When it comes to psychiatry, there's so much that we can do, and we have these great tools that we use, and we have medications. But there are definitely limitations that you see when you're in actual clinical practice. So today I'm going to just go into make one point that I think will help maybe shift how all of us think about behavioral health disorders in a way that we can get better outcomes for our patients. But let me start by telling you a little bit about this data analyst, this famous one who made a point that when you look at the human population, on average, each of us has one testicle and one ovary. So that's an accurate statement, right? But when it comes to the practical use of that knowledge, it doesn't actually apply. It's not that useful. And that's the thing, is the way you ask the questions, the way you look at things really will determine, whether or not the final outcome is helpful. So take a look at this picture. And here you see this dog. And some of you, look at the dog and, is this dog black? Is this dog white? What do the characteristics that you can assess, what can it tell you about the dog? Is it going to be a dog that bites, that's nice, like what are the personality traits? Who is this, what kind of animal is this going to be? You wouldn't use that kind of information to be able to make all these deep inferences about the characteristics or what's happening with this animal. But that's kind of what we're doing in terms of our work. Psychiatry, we know, is a huge market. $225 billion is spent annually on mental health care in the U.S. The cost of absenteeism is $51 billion. So we're spending all this money. You would think that, yes, we're having an impact, we're helping to get people better. But still, there are 149 million people who live in mental health shortage areas throughout the U.S. And when you pull the lens back and you look at the whole world, at least a quarter of the people around the world will be impacted by some mental health issue at some point in their lives. So it's a huge problem, right? We all know this. And despite that, we find that, psychiatry and just medicine in general, in terms of the tools that we're using, we really look at these superficial characteristics in terms of the DSM, in terms of behaviors, right? So when you think about how we diagnose people, we're looking at, all these symptoms that occur together, and then we put them all in these buckets, right? So those buckets define, what the disorder is. And then from that diagnostic checklist, we then come up with prescriptions for patients. And what's happened is we've simplified the process to the point where people think anyone can do psychiatry. You don't even need a person, right? You can just give a questionnaire, and from the answers that are provided, you know what's going on, quote unquote, with the patient, and then you have a clear protocol of what to do. And it's at a place where a lot of psychiatry, in terms of the medications, in terms of the diagnosis, the treatments, not even being done by psychiatrists. There are 45,000 psychiatrists in the U.S. We all know about the shortage that in terms of 50 to 30,000 that's expected. So even with that amount and that shortage, we see that we're making up the gap with 80% of psychiatric medications being prescribed by non-psychiatrists. So we have this process where we've simplified how we diagnose, and we have a treatment process where it's not being done by people who even have the training in psychiatry, and also there's limited time in terms of their interaction with the patients. A primary care doctor will spend, on average, 6 to 10 minutes with a patient. For our team, we're spending about 40 minutes with a patient. So the ability to have a relationship with the patient, to get to know the person, to look deeper at what's happening with them, takes time, and we're not investing that time in terms of how medications are being offered to people. And at the same time, we're also adding non-physicians, with psychologists being given prescribing authority in multiple states, So they don't have that medical background. They're not thinking biologically about the cases, but yet they're able to prescribe the medication. And again, it's because we've defined psychiatry as being these diagnostic checklists and then simply having medications that will treat those conditions. One example of the challenges is, when you think about SSRIs, you've all heard heard of the medications, but you may not all know how it works. So an SSRI will look at, work here. Sorry, one second. So if you look here, so this is the presynaptic nerve ending, right? This is a vesicle where serotonin is made and is packaged in this vesicle, and then it docks here. And when there's a stimulation in this neuron, it will stimulate the release of the serotonin into that synaptic cleft, the space between the two neurons. And then the serotonin will then bind to postsynaptic receptors and then presynaptic receptors. And then the body's very efficient. It likes to recycle it. And that happens through the serotonin transporter or this reuptake process. And SSRIs, what they're doing is they're blocking this transporter, and that's helping to increase the level of serotonin in the cleft between the two neurons. The end goal, the desire, is that you want to bump up serotonin. This is a molecular process that's happening. In the way we think about the care, we just focus on the symptoms that we saw on the surface and this medication, but there are other steps that are happening when it comes to serotonin that we don't think about. So psychiatrists put up their white coats a long time ago. We really, we shifted where we do therapy and we do this, the diagnostic process, but we don't think about what's involved in the molecular processes behind any condition that we're seeing. So for example, when you think about, the SSRI, well, if you're trying to bump up the levels of serotonin, you can also start thinking about the whole molecular pathway of serotonin. So the prior slide, this is us just thinking about, again, the symptoms on the surface and then the medication. And this is what we would call, with functional medicine or biological psychiatry, where we're now thinking about all the steps involved in making serotonin. The process starts in the gut, right? With hydrochloric acid and the gut biome. That's where you break down your food to actually get the tryptophan that you're now going to need to then get from the tryptophan to the 5-HTP, which then eventually gets converted into serotonin. And what you'll see is that here in the boxes, these are cofactors, right? So these cofactors, these vitamin B6, folic acid, iron, magnesium, calcium, vitamin C, and zinc. So all these cofactors are important for making serotonin. And what we did in our practice is we shifted from years ago from just simply saying, hey, we've looked at you, we've decided that you have depression, and we're going to give you an SSRI. We shifted to thinking more scientifically, looking more at the whole pathway, and just having this idea of supporting the pathway. And what we found is that we were getting great outcomes with our patients. So we would check to see what were the levels of these different factors that are involved in making serotonin. This would be combined with the medication, with the SSRI. So the medication still is critically important, but you're helping the body produce it first, and then that SSRI is functioning as a dam, which helps to boost it. But then this is why you'll see, people talking about how different vitamins can have this effect for people in terms of addressing their mood and addressing their anxiety. For those people who happen to be deficient, having issues at certain parts of this process, that's why maybe they're responding to that additional supplement in addition to the medication. So the key idea here is that a lot of, we've seen this investment in behavioral health, right? With COVID, lots of money, lots of attention being paid. And what we did is we accelerated this process, right? So people wanted to put money, and business people wanted to apply tech to a framework that doesn't get most people better. Like even when you say a medication is effective, you might have a 30 some odd % response rate. So 60+% of people, over 60% of people are not responding to that care. But what we did is just found ways to accelerate it where the financial incentives were about getting to a diagnosis quickly and figuring out what's the right prescription to give. That was the focus, that was the goal. And a lot of the models where we're looking at analyzing it, we're saying we want to apply AI, we're going to use computers to help improve the care that we do. It gets back into that issue of what are you looking at? How are you organizing the data? And is this the framework that we're using to then help apply AI to psychiatry? And the key idea is that we want to shift from just looking at this one step of the process to, in our thinking about behavioral health conditions, we want to think about molecular pathways. We want to get back, as psychiatrists, get back into looking at the biology of our patients and realizing that the psychiatric symptoms that we're seeing are just one facet of these underlying processes that are going on. And this is the good data that can be used to help really get us some meaningful outcomes in terms of patient care. And based on the clinical work that we're doing, we're seeing this. So, so what's different about SohoMD versus other companies? A lot of other companies where they, really focusing, I think, on, the business and tech, and applying it to what was there. For us as doctors, we had been in practice for years and we'd run into the challenges of trying to get our patients better. And we were not getting the outcomes we wanted with all the cases, and that's why we had to expand the work that was being done to look at what are the possible options in terms of how care is done, what people are saying from functional medicine, from biological psychiatry, just really looking at the full range of possibilities and finding a good way to combine them. And it creates this framework, which I think, again, sets the stage for having the right thought around how to organize clinical data in behavioral health so that we get meaningful information when we analyze it. In terms of the companies, so we address our health holistically, where we're looking at the full range of conditions. We also focus on the quality of life. So it's not just about, did we get your symptoms better? Is it, your GAD-7, your PHQ-9, did your score get better? The questions we had, are relationships better? Are you doing better at work? And then that really pushes you to look beyond, the just simple prescriptions. Also, a lot of people focus on therapy and prescriptions, but we look at also nutrition, lifestyle, and supplements. So just the full range of things. And that's what it takes to get that person's life better. In terms of the care, we do integrated care in teams, which I'll touch on in a second, talk about more in a second. We also focus on employing people versus having them as consultants because we want them to buy into this notion of quality as being the priority for working with us. And we've also entered into digital therapeutics. And finally, the most important part is we have great outcomes with our patients. We're seeing that we're able to emphasize non-prescription treatments, so therapy, lifestyle, other things. And also we're eliminating long-term reliance on medications when they're not necessary. And we're seeing 88% of our patients improving with the care that we're doing. So patients are doing extremely well. We're really proud of what we've accomplished by how we're thinking about approaching behavioral health. Team care model. So how do you take clinicians, how do you get them to do this great work? People aren't trained to think biologically, think about nutrition, endocrine issues, all these other factors that can impact care. The first thing we did is we really focused on getting care coordinators to help decrease the administrative friction that exists. So they did decrease the administrative friction between the patients and clinicians with other clinicians. And that way our providers can just focus on the work that they're doing. And then the mental health providers, when they come into the practice, we train all the therapists on doing trauma work. We train all the prescribers on understanding what integrated biological psychiatry is. Not necessarily for them to be experts in it, but for them to understand how to connect to other experts who can then help them get a robust treatment plan to make their patients better. Those providers, in turn, have access to a complex care panel where we do have experts in endocrinology, physiology, functional medicine, a wide range of areas that can then give them be part of their treatment team to then go back and have these robust treatment plans for patients. And what this does is it really decreases the stress for the provider because they're supported on one end in terms of all the administrative workload that burns most providers out. And on the other side, they're also supported clinically, where they really are able to get insights into how to approach the care, how to really help get their patients better. So the old model of thinking about psychiatry was just, what's the prescription? How do I diagnose? How do I get the right prescription? Here, our providers are thinking about what are all the nuances of what's happening biologically with my patient? What can I do to really think about it? What can I do to address it? I can't tell you how many patients have come in where, they think they have attention issues, they have a B12 deficiency, right? But other places would have simply said, oh, you meet criteria based on this questionnaire, you need a stimulant, and here you go. For us, we dig deep and we find what's really going on with this person and what can we do to help them get better. And so everyone in our team really enjoys what we've created. So we have the quality in the session. In between sessions, we've been working on an app which is coming out this summer. It's going into beta testing. It's our first entry into the process of collecting more information from the patients where we can incorporate it into the care that we do. We partnered with one of the top gaming companies out of the UK, where we created a way to capture things that make you anxious in the real world and then use evidence-based approaches to help decrease the anxiety. We've been working on this for a while, and it should really be a really key part of our future offerings, so we're very excited. In summary, in terms of the company, so just quickly, it's built to maintain quality at scale. So we organize everything in these teams so that no matter how big we get, we'll always be able to have that support, both clinically and administratively for providers, so that they can do great work. We're already in 21 states. We've been self-funded the whole way. We're going through our first round of funding now. We're looking at an institutional round. But we've been really focused on clinical quality because we didn't have any external mandate. We didn't have, we didn't have to worry about, dealing with investors early on. So we could really focus on being clinicians, really, how do you improve the quality of the work that we're doing? And that, that's what took us a while to put together, but that's what we've done, and now we're looking to scale that up. Our employee satisfaction is incredibly high. You've heard of like moral injury, where people, you get burnt out, you're doing work that just is not consistent with, what your priorities might be. Because we've focused on creating the supportive environment, we really do have very happy employees and actually have a waiting list of providers who want to work at our organization. A lot of people talk about recruiting challenges, and for us, that has not been a challenge over the years. We're entering digital therapeutics, as I mentioned. And finally, the company is, we're looking for partners who need access to high quality mental health. We make it affordable, we make it accessible for patients, and we're looking, at ways of expanding it. But the take-home message that I want to leave you with is how you judge, the pet, how you judge patients. What are the buckets that you're using to organize the data to help make decisions around what you're going to do? And currently, the diagnostic framework in psychiatry doesn't help you get to the best answers. And if we simply shift to the biological framework to really dig deep, because now we have the tools with genetics, with nutrition, with endocrinology, we have the tools to look at the biology of our patients and then make correlations to those symptoms. We then have a much more effective way of assembling this data set that you can then train with AI to then get meaningful conclusions and recommendations that will actually help the patient. So we've demonstrated this based on our operations, based on our clinical work, and now I think we can add the tech and apply it in that way to really help bridge the gap and get everyone mentally well. Thank you.